Hi, my name is Tripti Nagar. I'm currently a third-year internal medicine resident at APRH. Today, I'll be discussing our QI initiative in decreasing the overutilization of proton pump inhibitors in the inpatient setting. To get started, proton pump inhibitors are commonly used medications seen in the inpatient setting for the treatment of GERD and erosive esophagitis, as well as prophylactically in patients who have a high risk for stress ulcer formation. Long-term PPI therapy, however, is associated with an increased incidence of infections, particularly C. diff infections, community-acquired and hospital-acquired pneumonia. Nutritional deficiencies like B12 deficiency has also been demonstrated in literature, and these medications also have a higher risk of fractures. Because of this, appropriate adherence to prophylactic indications is important in our patient population. Discontinuing stress ulcer prophylaxis on hospital discharge and reevaluating the continued need for therapy in our patients is an important step in the prevention of continued use during readmissions. Chronic inappropriate usage of these medications can predispose patients to increased medication adverse effects and increased institutional costs. Our QI study was developed to assess and reform the process of inpatient PPI prescriptions based on clinical indications of therapy with a goal of reducing utilization by 30% over the course of 1 year, beginning in July of 2023. To do this, we initiated a PDSA cycle to determine a process for improvement. In the pre-intervention phase, the data was collected over a 2-month span to obtain background information on patients who were given PPIs inpatient. This included demographic information, a reason why the PPI was started, how long the patient received PPI therapy for, as well as any side effects that they developed over the course of their admission. When we analyzed this data, we had 186 charts to review. Only 32.8% of these patients had an appropriate indication for stress ulcer prophylaxis, which meant that 67.2% of patients were inappropriately prescribed with PPIs. 17% of patients developed an adverse effect to their medication during their inpatient course, and 52.9% of patients were discharged with a new prescription for PPIs that they weren't previously taking before they were admitted. Data analysis also showed that overutilization occurred with all inpatient admissions, including those admitted under a teaching service. Our intervention consisted of an education session that reviewed indications for stress ulcer prophylaxis, contraindications, and the adverse effect profile of these medications. This presentation was presented to the academic internal medicine, family medicine, and transitional year residents. Advanced practice providers who were involved in the admission process for non-teaching attendings were also included in this education. To analyze how effective this intervention was, our post-intervention data was collected and 301 charts were reviewed. Of these patients, 169 patients did not have a prior diagnosis that justified inpatient initiation of PPI therapy. Only 35% met the criteria for starting stress ulcer prophylaxis. This, however, was a 3% increase in appropriate utilization when we compared it to our pre-intervention data. Looking at discharge data, 27% of patients who were PPI naive prior to admission were prescribed a PPI upon discharge. This was a 25.7% improvement in reducing unnecessary medication on discharge. The development of side effects in the inpatient course remained rather uncommon. However, most commonly we saw side effects including electrolyte disturbances, which can pose an increased risk for patients who present with cardiac or renal comorbid conditions. Our study demonstrated a decrease in inappropriate inpatient PPI administration by 3% after multidisciplinary education was completed. Although our post-intervention sample size was larger, the education session demonstrated a positive response within 1 month after education was completed. We anticipate to continue to decrease inappropriate PPI utilization in the coming months. Our post-intervention data also demonstrated an increase in the incidence of side effects due to a larger sample size compared to our pre-intervention group. This further substantiates the need for decreasing inappropriate use in patients who do not meet stress ulcer prophylaxis criteria. To maintain this trajectory, our next PDSA cycle is aimed at optimizing the EMR order options to provide only 3 orders for pantoprazole: one for oral administration, one for IV, and one for infusion. Each order will require selecting the indication before ordering and administering the medication. Those patients who require pantoprazole as a home medication will be reconciled through their admission medrec system. Thank you for your time. Our next session will be the Q&A.